In 2017, a man named Drew Calver had a heart attack. He was 44 years old, a high school teacher in Austin, Texas, healthy by most measures, insured. The ambulance took him to the nearest hospital. The surgery saved his life. 4 days later, he was home. 6 weeks later, the bill arrived. $109,000. That $109,000 was his personal balance, after insurance. Drew Calver was a public school teacher. The bill exceeded more than double his annual salary for 4 days of care that kept him alive. This is not a story about bad luck. This is not a story about a broken system. This is a story about a system working exactly as its incentives were built to work. And it is the most expensive system of its kind in the history of the world. The United States spends more money on healthcare per person than any country on earth. Not slightly more. According to OECD health statistics, the US spent $12,555 per person per year on healthcare, figures covering 2023 spending. The OECD average across 38 wealthy nations stood at $4,986 in that same year. The United States spends more than 2.5 times the average of every comparable wealthy country. More than Germany, more than Canada, more than Japan, more than every nation with universal coverage. Now here is the number that should stop you completely. Americans live shorter lives than the citizens of most countries that spend less. US life expectancy in 2023 was 78.4 years, recovering slowly from a sharp pandemic decline, and reached 79.0 years in 2024, according to the CDC National Center for Health Statistics. Still trailing. Germany, 81, France, 82, Japan, 84. Americans pay the most and die the soonest. This is not a paradox. It is the logical outcome of a system built around a different objective than health. Now, before we go further, it's worth saying this clearly. American medicine leads the world in pharmaceutical innovation. American hospitals achieve some of the highest cancer survival rates on Earth. Access to specialists here is faster than almost anywhere. The system is not medically broken. The problem is simpler and harder to fix. It is economically inverted. Every system produces exactly what it is incentivized to produce. The American healthcare system is not primarily incentivized to keep you healthy. It is incentivized to treat you when you are sick. There is a difference. And that difference is worth $4 trillion a year. Consider how the system earns money. A hospital earns revenue when beds are filled. A pharmaceutical company earns revenue when prescriptions are written. An insurance company earns revenue when premiums are collected, and reduces its costs when claims are denied. None of these revenue streams require you to be healthy. Several of them perform better when you are sick. A 2018 study published in JAMA, the Journal of the American Medical Association, compared the US healthcare system against 10 comparable wealthy nations. The researchers found that the US did not have significantly worse access to physicians or hospital beds. What the US had was dramatically higher prices for identical services. An MRI that costs $150 in Spain can cost over $1,020 in the United States, for the same machine, the same scan, the same result. This is not inefficiency. This is a pricing structure built on the absence of unified negotiation. This isn't because Americans are greedy, it's because the incentives were built this way, and they reward volume, not value. In every other wealthy nation, the government negotiates the price of medical services directly. A hospital cannot charge 6 times the global rate when a single national buyer controls the contract. In the United States, that negotiation never happens at scale. Instead, there are thousands of overlapping insurance plans, provider networks, and billing intermediaries, each negotiating separately, each with less leverage than a unified system, each adding administrative cost that other nations simply don't carry. A 2019 study published in the New England Journal of Medicine found that administrative costs consumed 34.2% of total US healthcare spending, compared to 12.4% in Canada. That gap represents over $800 billion per year, not spent on doctors, not spent on nurses, not spent on medicine. Spent on the machinery of billing, denying, appealing, and processing claims across thousands of competing systems. Think of it this way. That $800 billion exceeds the entire annual defense budget, spent on paperwork instead of care. And patient confusion inside this complexity is not a side effect. It is, structurally, a feature. Here is the sentence no industry brochure will ever print clearly. Not because it's secret, but because it's structural. The United States does not primarily have a healthcare system. It has a sick care system. The structure of American healthcare spending tells its own story. The US spends the majority of its $4 trillion annual budget on treating conditions that research consistently shows could be prevented or delayed. According to Milken Institute analysis, every dollar invested in preventive care returns between $5 and $7 in avoided treatment costs. Countries that invest more upstream spend less downstream, live longer, and pay less overall. The US healthcare system knows this math. Prevention, however, does not generate billable events. More treatment, less prevention, higher cost, shorter lives. The system is not medically broken. It is economically inverted. Roughly 4 in 10 American adults currently carry some form of medical or dental debt. Not people without insurance, not people who made reckless decisions. According to the KFF Healthcare Debt Survey, this number has not meaningfully improved since 2022. More Americans have medical debt than have student loan debt. Medical debt is among the top contributors to personal bankruptcy filings in the United States, and this is the only wealthy nation where illness routinely triggers financial collapse. In no other comparable wealthy nation is a hospital bill a long-term threat to a family's financial stability. This is not because Americans are less financially prepared. It is because the pricing structure of American healthcare was never designed around what patients can absorb. It was designed around what the market can extract. In 1923, the inventors of insulin sold their patent to the University of Toronto for $1 each. Frederick Banting, Charles Best, and James Collip believed that a life-saving medication should not be owned by private interests. For decades after, the pricing remained accessible. Then the architecture changed. By 2022, according to Rand Corporation analysis comparing the United States against 33 OECD countries, insulin prices in the United States were more than 9 times higher than the international average. The Inflation Reduction Act of 2022 established a cap of $35 per month on insulin for Medicare Part D beneficiaries, a protection that began reaching patients in 2023. But that cap does not cover the more than 150 million Americans under the age of 65. For them, the pricing gap remains. In December 2017, a 26-year-old man named Alex Smith aged off his parents' insurance. He could no longer afford his insulin. He began rationing. He died 27 days later from diabetic ketoacidosis, a condition entirely preventable with access to a medication that costs less than $1 to manufacture. Alex Smith did not die from diabetes. He died from a pricing system. A 2021 study in the American Journal of Public Health estimated that over 1 million Americans rationed insulin due to cost in the prior year. One medication, one price structure, 1 million people choosing between insulin and rent. The healthcare trap does not only affect the uninsured. It affects everyone inside the system, including people who believe they are fully protected. Here is why. The structure of American health insurance is built around a concept called the deductible, the amount you pay out of pocket before your insurance begins covering costs. The average deductible for an individual in an employer-sponsored plan in 2023 was $1,735. For a family plan, $3,811. Before insurance pays a single dollar, a family must absorb nearly $4,000 of medical cost. This means that for routine illness, the kind that strikes most families most years, insurance provides no financial coverage at all. The premium is paid, the deductible is paid, and then insurance begins. A 2023 Federal Reserve study found that 40% of Americans could not cover an unexpected $400 expense without borrowing money. The average medical deductible is nearly 10 times that amount. And Drew Calver's situation adds one more layer. His hospital was not in his insurance network. In 2017, a practice called balance billing allowed a hospital to charge patients directly for the gap between the insurance payment and the hospital's full listed rate, with no cap, no warning, and no negotiation available to the patient. The No Surprises Act, which took effect January 1, 2022, now provides federal protection against many forms of surprise billing, particularly in emergency situations. Drew's case happened 5 years before that protection existed. But the underlying architecture that made his bill possible, out-of-network pricing, opaque negotiated rates, and deductibles that activate only after the crisis begins, remains structurally intact today. The protection improved, the system did not change. There is a version of healthcare that builds long-term population health. And there is a version that builds quarterly revenue. The difference is not the quality of doctors. It is what the system pays doctors to do. In the United States, the dominant model pays physicians per procedure, per visit, per test. More procedures, more revenue. More tests, more revenue. More prescriptions, more revenue. A doctor who keeps a patient healthy through lifestyle intervention generates less billable activity than a doctor who manages that patient's chronic disease over decades. The system does not primarily reward health outcomes. It rewards billable events. This is not a criticism of physicians. Most doctors entered medicine to heal. It is a structural observation about what the financial architecture of the system incentivizes at scale. Countries with better health outcomes have moved toward value-based care, paying providers for outcomes, not procedures. The US has discussed this transition for 30 years. The industry that profits from the current model has invested 30 years in ensuring the transition remains incomplete. You cannot individually opt out of American healthcare pricing, but you can change how you move within it. 3 frameworks that reduce your exposure. First, know the difference between insured and protected. Having insurance does not mean you are financially protected. Before a crisis, not during one, calculate your maximum out-of-pocket exposure. If that number would destabilize your finances, your coverage is insufficient for your actual risk level. Second, use the price transparency you are legally owed. Since January 2021, US hospitals are legally required to publish their prices in machine-readable format and in a consumer-friendly display, meaning you can compare costs before committing to care. The rule is called the Hospital Price Transparency Rule, enforced by CMS, the Centers for Medicare and Medicaid Services. You can search it directly on cms.gov. Most hospitals make this data difficult to navigate, but it exists, and it is your legal right to access it. Tools like Healthcare Blue Book and Fair Health Consumer allow you to compare procedure costs across facilities. A procedure costing $8,000 at one hospital may cost $2,000 at another facility 3 miles away. The quality of care is often identical. The price is a negotiation, not a fixed rate. For medications, GoodRx and Cost Plus drugs frequently offer prices lower than insurance-negotiated rates. Third, understand that prevention is the only arbitrage the system cannot price against you. Every dollar spent on preventive care returns between $5 and $7 in avoided treatment costs. The system is not incentivized to tell you this, but the math is not ambiguous. The most effective financial strategy inside a sick care system is to minimize your need for it. Drew Calver, the teacher from Austin who owed more than $100,000 after a heart attack, eventually had his bill reduced. After a journalist published his story, after the hospital received national attention, after public pressure made the original bill untenable. His debt was settled for $332. The same procedure, the same hospital, the same 4 days. $109,000 became $332 when visibility created accountability. The price was never fixed. It was a negotiation that only one side knew was happening. This is the deepest pattern of the healthcare trap. The system operates on asymmetric information. The hospital knows the real price. The patient does not. The insurance company negotiates behind closed doors. The patient pays whatever remains. In every other market, a buyer who doesn't know the price pays more than a buyer who does. Healthcare is the only market where the buyer is structurally kept from knowing the price until after the purchase is complete. The knowledge gap is not accidental. It is load-bearing. In 1923, Frederick Banting sold the insulin patent for $1. He believed insulin belonged to the world. 100 years later, the world pays $8 for that insulin. Americans, outside of Medicare coverage, can pay 20 times more. The gap between those two numbers is not a medical gap. It is not a scientific gap. It is not a gap in the quality of care. It is a pricing gap, built through incentive structures, maintained through legislative complexity, and funded quietly by the $109,000 that Drew Calver didn't have. The healthcare trap is not about your health. It is about who controls the price of staying alive, and what they are incentivized to do with that control. You cannot fix the system alone, but you can stop being surprised by it. And in a system built on asymmetric information, not being surprised is the first form of power. The first step is the same as every trap in this series. See it clearly. Because the moment you understand that the bill is a negotiation, that the deductible is a structural design choice, that price transparency is your legal right, you stop being a passive patient inside their system. And you start being someone who understands exactly what they are paying for, and who benefits when they sign. We have talked about reputation that gatekeeps income, intelligence that doesn't translate to wealth, salaries that evaporate, ownership that stays out of reach, starting that never happens, debt that quietly compounds, and now a system that charges the most and delivers the least. But there is one trap that makes all the others worse. It doesn't take your money directly. It doesn't attack your body. It steals your ability to think clearly about any of this. Your attention, your focus, your capacity to act. That's the attention trap. Next,